Good morning, everyone. So today we have a special lecture by Dr. Vivek Saraswat, who is the Chief of Hepatology at Mahatma Gandhi Medical College after serving for a long time at SGBGI Lucknow as the Chief of Gastroenterology there. So he is going to talk to us about acute variceal bleeding. I think it's very important for surgical students to know that what are the non-surgical methods of control of acute variceal bleeding, because in large majority of cases, that will be the treatment rather than surgical management. Surgery would hardly ever be required in very few cases as a salvage when these measures are not possible for some reason or not successful, which is a rare situation today. So we will learn about non-surgical control of acute variceal bleeding from Dr. Saraswat.
Thank you, Professor Kapoor. Good morning, everyone. So in the next half an hour or so, well, almost about 35-40 minutes, I'll take you through what are the current concepts in the management of acute variceal bleeding. This is a very large topic, quite extensive. I'll try and concentrate on the important areas and cover as much as is possible in the time available. So these are small, these are large esophageal varices, and these are gastric varices seen in the retroflexed view in the fundus of the stomach. When we talk about esophageal variceal management, what we need to know are some of the points highlighted here are: how do you classify and grade the size of esophageal varices? Can we predict the risk of esophageal variceal bleeding with the endoscopic and other tools that are available to us? What are the various ways of endotherapy? Endoscopic sclerotherapy, also known as endoscopic injection sclerosis of varices, and endoscopic band ligation or endoscopic variceal ligation, which is the current standard of care. Prophylaxis, interventional radiology roles, surgical management, all these are very large areas in themselves. So in this talk, I'll basically talk to you about classification of varices, a bit about predicting the risk of variceal bleeding, and the various techniques available for endotherapy of esophageal varices. Now, what are varices? These are extremely dilated submucosal veins seen in portal hypertension at sites of portosystemic communications, which are well known, and the ones that usually concern us is the esophagogastric junction, also to some lesser extent rectal varices, and then we have a host of ectopic varices, which may be esophageal, gastric. Ectopic would be duodenal, intestinal, rectal, stomal in cases of surgical stomas being created. These are the various common locations of ectopic varices. Now, how do you grade varices? Varices were identified a long time back. With the available of flexible endoscopy, the information on this exploded. And the first important classification was given by Degrady et al. In 1996, and subsequent classifications have been given by Paquet from Germany, Beppu from Japan, then the North Italian Endoscopy Club, as well as the American Association for Study of Liver Disease have given their different classifications. The initial classification by Degrady was from grade 1 to grade 5. It was a descriptive classification, fairly detailed in the first ones, but has largely fallen out of favor presently and is not used currently, as the trend is towards simplification of the classification and description systems. In line with this, Paquet, who is a German worker from Hamburg, he had initially given the Paquet classification grading varices from grade 1 to grade 4, of which if you look at grade 1, varices seen only in inspiration, effaced during expiration or by air insufflation, refers to a fairly subtle grade of varices, which may be very subjective. So in the subsequent modified Paquet classification, this grade 1 has been dropped, and the what is 2, 3, 4 here has become 1, 2, 3 in the modified classification. Well, grade 1 being varices projecting just above the mucosal level and are not flattened by air insufflation, so they are definite varices. This distinguishes them from the standard mucosal columns, that 3 or 4 columns that are present in the esophagus and are effaced by air insufflation. Varices projecting up to 1/3 of the luminal diameter are considered as grade 2 varices, and varices projecting up to half or more of the luminal diameter, and which may at the lower end of the esophagus almost be in contact with each other, are termed grade 3 varices. So this is a pictorial representation of what I've just said. Esophageal varices grade 1, as you can see, they're clearly elevated above the mucosa and can be discerned. As you can see, the straight column, these other irregularities, nodularities here, and these are most prominent or best assessed at the GE junction or just above the GE junction. Grade 2 varices, projecting up to 1/3 or less of the lumen, but not flattened by air insufflation. They can be straight, nodular. Generally, because they are not very large, they have a pinkish mucosal covering, but as they become larger, they take on a bluish hue and can be seen extending even into the upper portions of the esophagus. Grade 3, large varices, tortuous, nodular, bluish in color, almost occupying the complete lumen or more than half the lumen in the lower esophagus, are grade 3 varices. And apart from the presence and the size and extent of varices, what is also important is the red color sign over varices. So what is the red color sign? These esophageal varices with red wale markings, these reddish markings, these are varices on varices appearance that has been reported. These are cherry red spots, nodular reddish spots in grade 2 varices, and the same signs, cherry red spots, red wale markings, and hematocystic spots are larger. Cherry red spots are 5 millimeters or less. Hematocystic spots are blebs in the mucosa, which may be more than 5 millimeters, and these are called hematocystic spots. All these are predictors of the risk of bleeding in varices. This is basically the same thing shown again here. These are varix on varix appearance. You can notice this nodular appearance of red wale markings, red color signs with the varix on varix sign. And these are subepithelial veins. Varices are submucosal. And this is an adherent clot on a grade 2 varix. All these are part of the red color sign and are indicative of the risk of bleeding. Now, how do we predict the risk of bleeding? Roberto Di Francis and they started the North Italian Endoscopy Club in 1988. This was when there were randomized controlled trials going on to determine the risk of first bleeding. So based on the grading of varices, they had developed a predictive score to predict the risk of first esophageal bleed in a person who had never bled before and has probably not been validated for those who have had previous bleeds, for recurrent bleeding, but still is a very valuable tool to understand the risk of bleeding. So it was they constructed six risk categories based on a complex point systems looking at these three parameters: the child status A, B, C, and these are the points given for A, B, and C. Size of varices, small, medium, large, and this is the score given for the size of varices. And the presence of red wale markings, none, mild, moderate, or severe, accordingly points given. And so the total points would be less than 20 or more than 40, giving the risk of bleeding. And based on this is a panel that is constructed, child's grade, size of varices, and red wale markings. So, small varices without red wale markings in a child's A patient has a 6% or less risk of bleeding, while similarly, prominent red wale markings in a child C patient with large varices, the risk of bleeding the next 6 to 12 months. This was the projection given, and repeatedly in various prophylactic situations, this risk of bleeding has been validated. And it basically provides us with a mental picture of when you look at varices, that how likely is to happen in the near future in these patients. So overall, while assessing varices, points to be borne in mind are that variceal grading should be carried out in the lower esophagus just above the gastroesophageal junction. Your reporting of the varices should include not just the location, but also the number of columns, length of columns, the diameter of varices, color and tortuosity, and the red color sign. For example, a typical report for grade of varices should mention that using the modified Paquet classification, these are grade 2 columns, varices. 4 columns are seen, extending from the Z line, generally 38 centimeters to say 20, 25, maybe even 30 centimeters. The approximate diameter 5 to 10 millimeters, bluish in color, tortuous with a red color sign present, that is red wale markings, no cherry red, no hematocystic spots. So this gives a very clear and a standard description of varices and also allows you to construct a possible risk of bleeding in this patient. One should stick to one system. Quite often we find people mix elements of the various systems. The Beppu classification with the package, for example, is very confusing. The other thing is that one esophagus has one grade of varices. It is not so uncommon for us to come across residents or students reporting one grade 3 column, one grade 2 column. Now that is not correct. The grade is a single, the bleeding risk is related to the grade, which is related to the largest varix. So if it is a grade 3 varix, the other columns may be 5 millimeters or less. The esophagus still has a grade 3. Okay. Now coming quickly to various ways of managing esophageal varices. What is the risk of bleeding? What predicts the risk of bleeding? Currently, the theory that holds is the explosion rather than the erosion theory. Once upon a time, it was held that reflux of acid eroding the thinned out mucosa over the columns precipitates bleeds. But I think preclinical now most experts are convinced that the bleeding happens as a result of sudden increase in intraluminal pressure, just as happens during a Valsalva maneuver, for example, and is subject to the Laplace's law, which says that the wall tension is directly proportional to the intraesophageal pressure, that the pressure that the blood is exerting on the wall is directly proportional to the radius of the vessel. So the larger the vessel, the higher the risk, and is inversely proportional to the thickness of the to the wall thickness of the variceal column. So the bleeding risk is highest for large varices with a red color sign. And this again is diagrammatically understandable. There's much less wall tension when there's a narrow duct and a thick wall and a narrow column. Whereas with a large column and the stretched out wall, the risk of bleeding is much greater. So a few things that might be borne in mind about endoscopic therapy. Well, the first efforts at endoscopic therapy are quite old. 1936, Crawford and Frankner, using a rigid esophagoscope, were the first to carry out sclerotherapy using a sclerosant in variceal column. However, systematic work on this and using it repeatedly and reporting a series of cases using the rigid esophagoscope was done by Terblanche et al. In 1952. Subsequently, series published from Japan, Germany, the UK, this is again Germany, and then from India, were published on sclerotherapy using a variety of sclerosants that I'll come to in a minute. Variceal band ligation was first reported in the NEJM using a single band ligator by Stegman and Goff in 1988. And an overtube in which multiple passages of the scope were required to place multiple bands was used, but this was subsequently modified, and multi-band ligator, where with the single introduction of the scope and multiple bands can be placed, has now become the standard of care, and many robust devices and very quite cheap and economical are available. Now talking about sclerotherapy, the sclerosant is injected through the sclerotherapy needle, which goes through the biopsy channel of the endoscope. The scope is quite long and we need the needle to be protruding at both the hub and from the tip. It is about 240 centimeters long. Usually it contains a coaxial plastic catheter to which a needle is attached, and into which into the outer catheter the needle can be retracted. And this may be either a plastic Teflon coaxial needle, or it may have this outer spring coil or coiled metal sheath, which is designed with the Olympus with a 21 to 23 gauge needle, and the needle projects about 5 to 8 millimeters beyond the tip. Using this, various sclerosants have been used in the concentrations and volumes that I've shown here, volumes per second and relative tissue injury. And generally the common and a popular sclerosant is ethoxysclerol or polydocanol. Other agents that have been used are listed here, and for which series and data are available. Absolute alcohol and sodium oroate and ethanolamine oleate are the most toxic and most injurious to the mucosa and to the tissues, while so the margin of error and the safety is that much less, while the efficacy is that much more when you use a sclerosant that has high extent of tissue injury. Now, the techniques that have been developed for endoscopic sclerotherapy can be intravaricial injection, as you can see in the diagram, and the endoscope in the esophagus with the needle protruded, the tip being protruded, and this is the variceal column. So directly puncturing the varix and injecting a certain amount of contrast till the varix blanches is intravaricial injection. While in paravaricial injection, the column is not punctured, adjacent mucosa adjacent to the column is punctured and blebs are created around the variceal column, which is the paravaricial technique. But it is not usually in the paravaricial technique, no more than 0.5 ml per is given per injection, and a large volume is used in a spiral fashion from the LES and proximally. You can well imagine in large columns when there's hardly any space between columns to get paravaricial injection, the lower esophagus is difficult, and this technique is better suited for small columns, grade 2 or less columns. In intravaricial injection, 1 to 2 ml of the sclerosant is injected per injection. Branching of the column is important. 10 to 20 ml per session is not to be exceeded. But more often than not, injections advertently or inadvertently, there is a combined injection. There is a bit of the sclerosant leaks out and is paravaricial, and much of the issue is an intended intravaricial injection, and vice versa. The inflammation induced by the sclerosant causes thrombosis of the varix and thickening of the mucosa or sclerosis of the mucosa, resulting in variceal obliteration. And post-EST, post-EVL ulcers are an intrinsic part of the injection treatment. After this injections, every patient will have lower esophageal ulcers. And depending on the depth and number of ulcers, problems like development of post-EVL strictures, dysphagia, some chest pain, fever, all these features may be noted. And following the variceal injection sclerotherapy technique, because the distal esophageal mucosa is thickened and the inflammation often extends into the perforator vessels that communicate with the paraesophageal venous channels, the rates of recurrence of varices is lower following sclerotherapy than it is with the variceal band ligation. So grade 4 columns, large esophageal varices, 1% ethoxysclerol being injected over a period of time after 3 or 4 sessions, eventually eradication of esophageal varices can be achieved, and the number of sessions depends on the volumes per injection that are used. Now to take you through esophageal variceal ligation, the variceal ligators that we have are now the multi-band ligators. So a transparent cup-like disc is attached on the tip of a standard endoscope, and a thread that connects this tip to the handle at the biopsy channel port is fixed firmly on the esophageal tip. Usually, like the size 6 shooter, there are 6 rubber bands placed, and the penultimate band is white in color so that one may be sure that now you have the last band available. And similar, this is the original developed by Cook, and similar indigenous like the V-grip, the speed band, and many other band ligators have been developed indigenously in our country, fairly cheap and just as good and as effective. So what do you do in the EVL? When you go down into the esophagus, focus on the varices, you have to have a good suction device available with you, and you apply suction, sucking in the columns into this. Between the tip of the scope and the tip of the band, there is a space into which the varix is sucked, and with rotating the handle at the suction biopsy channel, a band is dislodged, and it is applied over the varix. That's squeezing the varix. This is what the band does. The varix is sucked in and a band is placed, and varix column is then strangulated, And this is how it looks like endoscopically. You're viewing the varix through the band ligator. It has been sucked in, and this polyp-like elevation created when the band is applied on the esophageal column. I think hopefully this will run. So this is a video showing the same thing being done in real life, grade 4. So a diagnostic passage, you move down the esophagus, you see these nodular blue tortuous variceal columns all the way down to the Z line, the G junction, and with a prominent red color sign, red veil markings, red spots are present in this patient. So then you come out, apply the band ligator over the tip of the scope, and then go back in again. Slightly difficult to pass it through the pharynx, but not learned easily enough. Then you get down right to the lower GE junction. Here, what is, you can see the GE junction. To be very sure, you often go into the stomach to make sure that the first band is applied at the lowest portion, right? So you are just above the GE junction, and you're focusing these columns, and then you apply suction and suck the column into the polyp, into the band ligator, and then you release the band. A distinct click is felt. I think this column seems to have slipped out, so it's done again. The band didn't slip off. The first time when you rotate, you get a clear click when the band is released, and you can see that polyp has been formed. I think so. This way you do it repeatedly, and multiple bands are applied in a spiral fashion from the lower esophagus, and you can now see after 3 or 4 bands have been applied, this last band remains, and you have, as you move about, you do not wish to dislodge the previous band, so you have to come up a couple of centimeters each time, and the last polyp is quite small. And so finally, I think in this patient, there was not a large enough column in the esophagus beyond the last band to use the last band. So that was not placed. Now, quickly coming to a few definitions of how we assess our results in endoscopic band ligation. A lot of randomized controlled trials and series have been published, and unless the same terminology is used by all workers, there can be a lot of ground for confusion. So an acute variceal bleeding or acute variceal hemorrhage refers to active bleeding from esophageal or gastric varices at the time of endoscopy, or the presence of large varices with fresh blood in the stomach. You may not actually spot bleeding happening, but the blood is present and large varices are present. That would be accepted as an acute variceal hemorrhage. A clinically significant variceal bleed is one with blood unit more than 22 units is required within 24 hours from T0, or there is hemodynamic instability with tachycardia and drop in pressure or orthostatic pressure. Time frame is that T0 refers to the time of admission to the first hospital where the patient reaches after the bleed episode, while the acute bleeding episode generally in most situations in cirrhotic and non-cirrhotic patients refers to the first 5 days after an acute bleed. So this is important when you talk about failure, rebleeding, and so on. A failure to control acute variceal bleed after whatever endoscopic or pharmacologic techniques that are applied refers to the presence of either hematemesis, or if there's a nasogastric tube in situ, more than 100 ml of fresh blood 2 hours after the specific treatment has been started. For example, you put in a tube, you do a lavage and empty the stomach and put the patient on terlipressin. 2 hours later, if there is 100 ml of fresh blood again aspirated, then there is ongoing active bleeding. A presence of hypovolemic shock and a 3-gram% drop in hemoglobin. These are arbitrary definitions that had been put forward for the purpose of standardization during trials. And this is part of the UK guidelines on variceal bleeding. Rebleeding is a clinically significant bleed after 5 days. That is, if there is some bleeding happening on, say, day 2 or day 3, it is considered part of the index bleeding episode. Generally, if the bleed after a bleed-free interval and total duration exceeding 5 days, if bleeding recurs, and that is called variceal rebleeding. And significant rebleeding is as defined here, as mentioned earlier, while early mortality refers to death within 6 weeks of acute variceal bleeding. Now, these are some of the outcome predictors in acute variceal bleeding. Generally, in a cirrhotic patient, the first episode of acute variceal bleeding carries a 20% mortality risk within 6 weeks. Predictors of this mortality risk are that this is twofold higher after acute variceal bleeding happening in older age, that is 60 years or older, in people with comorbidities, in men, and in those in whom an early endoscopy, that is within 24 hours, is not done. It's one of the predictors of mortality in various studies. Similarly, predictors of early rebleeding, that is within or just soon after the 5 days, is poor liver function, MELD score above 18. Active bleeding at index endoscopy predicts the risk of rebleeding. Similarly, a high transfusion requirement or a high HVPG within 24 hours of the index bleed, above 20 millimeters of mercury, is a predictor of early rebleeding. And these facts have been taken into account for resorting that you achieve a hemostasis. Then during the interval before you 5 or 7 days, you need to move on to the next modality, whether it's surgical or tips or any other definitive modality for lowering portal pressure to avoid risk of rebleeding in high risk varices, because the bleeding risk in the cirrhotics are very high. So once a patient presents with bleed, the first thing one does is resuscitation. Depending on the volume of bleeding and the rate of bleeding, most of these people are best managed in an ICU setting with proper venous access and with the goal of maintaining a systolic pressure above 100 and oxygen saturation. Well, this is probably around 90%. With the active bleeding, before you proceed to endoscopy or other endoscopic interventions, often these patients may be candidates for intubation because you put in the scope and the patient vomits a profuse amount of blood, stomach being full of blood, that can be a life-threatening complication. Transfusion of blood and blood products is the mainstay when there's acute blood loss, but a restrictive transfusion policy is generally recommended to maintain a hemoglobin of 7 to 8 grams per deciliter once hemodynamic stability has been achieved. Obviously, once the patient is in shock or the patient is severely hypovolemic, volume restitution has to be done. And thereafter, over transfusion to get him back to 12, 13 grams is avoided, because that can result in recurrence of variceal bleeding. And this is a practice that has been associated with these benefits. That is, lowers the HVPG, improves the control of variceal bleeding, but at least in the early studies, it was not shown to change the mortality. That's now become standard practice. Platelets only if platelet count is very low, below 50. FFP if the fibrinogen is low or APTT is significant, INR APTT is significantly prolonged. People who are on anticoagulants and bleed may need prothrombin concentrates, etc. And there is no evidence that prophylactic administration of clotting factors or platelets reduces the risk of rebleeding, while for the use of things like recombinant factor 7A, which is very expensive, and tranexamic acid and other antifibrinolytic agents, there is no evidence to support the routine use of these agents to achieve hemostasis. So after resuscitation, stabilization, the moment the patient enters, vasoconstrictor therapy is now well established as the first line of care for pharmacology, for the pharmacotherapy for these people. And various agents include vasopressin with trinitroglycerine, terlipressin, the analog of synthetic analog of vasopressin, as well as other agents like octreotide and somatostatin, which are equally effective. Terlipressin, there are data and large number of studies and meta-analyses to show that it reduces that it. This is a negative way of stating that it improves control of bleeding, that it reduces failure to control bleeding. It improves survival. The usual initial studies were done using boluses of 2 milligrams every 4 to 6 hourly. Of late, I think the practice of continuous infusions of terlipressin being used has come into vogue and is equally effective. The Baveno 5, which has been reinforced by the subsequent Baveno consensus statements, recommends that vasoconstrictor therapy should be continued for up to 5 days. And in RCTs, data have been mixed, and when they've been compared with variceal band ligation, that is satisfactory hemostasis with variceal band ligation is also achieved when you continue therapy with the vasoconstrictors. The side effects include peripheral vasoconstriction, so pain, blue fingers and toes, and there may be ulcers, and even gangrene has been reported. So one needs to be cautious and on the lookout. And there will be a minority of patients who may not tolerate vasoconstrictor therapy, and then one may have to resort to alternative ways of achieving hemostasis. The other thing that have emerged from the data that have been carried out in this area is that antibiotics should be given to all cirrhotic patients with variceal bleeding. They have been clearly shown to improve survival by reducing bacterial infections. And interestingly, they're also associated with a reduction in early rebleeding rate. So, as we all know, following bleed with the drop in albumin, ascites formation, development of SBP are fairly common occurrences. And with the SBP, acute kidney injury, hepatorenal syndrome, mortality risks all go up. So, all cirrhotic patients who present with variceal bleed should receive intravenous antibiotics. And it has generally emerged that once that variceal band ligation is better than sclerotherapy or combination therapy, by reducing mortality, reducing esophageal stricture rate, and generally achieving obliteration in a 2.2 fewer sessions than with the sclerotherapy. So generally today, variceal band ligation is the standard of care. However, for once small size is achieved, then band ligation is not very effective. And if complete eradication is the goal, then that is where combination therapy, that is last 1 or 2 sessions using the lower esophagus with the injection sclerotherapy, are still practiced by many workers. So timing of endoscopy, how soon should endoscopy be done? It should be done immediately after the patient is stabilized following a severe acute once hemodynamic stability has been achieved. And this, whether it is 6 hours, 12 hours, or within 24 hours, various comparisons have been made. But overall evidence suggests that within 24 hours, there is the maximum benefit. And there may not be additional benefit of doing it very early, that within 6 hours or within 12 hours. So most units practice stabilizing the patient and then the next morning taking them up for sclerotherapy rather than middle of the night injection sclerotherapy or banding in a patient who's just maybe been stabilized or may not yet be fully stable. Now, what happens when there is failure to achieve hemostasis? If a patient has overwhelming torrential bleeding, he may not be, you may not be able to achieve stability enough to subject him to endoscopic techniques despite pharmacotherapy. And life-saving interventions such as the placement of a Sengstaken Blakemore tube to till the next definitive intervention, that may be either band ligation or a TIPS or shunt surgery, can be undertaken. And lately there is results and data with the Danisella stent, which is a self-expanding metal stent that can be then placed and has the advantage of allowing esophageal balloon will occlude the esophageal lumen, while with the metal stent the lumen is open, and once the bleed is stable, the oral intake, etc., can be resumed. Finally, as a salvage method, recently people have shown the efficacy of hemostatic powder spray, and I'll briefly talk about these. This is the standard Sengstaken Blakemore tube, the Rouge tube. Currently, globally, there are issues with the availability of the Sengstaken tube. We'll come to that in a minute. So these are the variants of these balloon tamponade tubes. The Sengstaken Blakemore tube, the typical one, has 3 lumens, one for the stomach lumen, one for the gastric balloon, one for the esophageal balloon. While the Linton Necklace tube used for gastric varices has a single large gastric variceal balloon and has various these channels for aspiration, for inflation and deflation. The Minnesota 4-lumen tube has been a variation of the Sengstaken tube in which a 4th lumen is introduced for esophageal aspiration. Because once you occlude the G junction by an inflated gastric balloon, esophageal secretions may accumulate and might get aspirated. So to prevent that, a 4th channel has been introduced in the Minnesota 4-lumen tube. So this is the, when it is inflated, this is how it looks, the Sengstaken tube. With the, you have to inflate with these check balloons. You can feel these balloons and make sure that the balloon, once you've inflated it, suppose a leak develops, and then the balloon will collapse inside, bleeding will continue, and this check balloon will also be deflated or collapsed. So once you've inflated and you've capped it, this is done. And then the important thing is anchoring the balloon. The balloon is passed down the esophagus with the help of the patient swallowing. So it is quite difficult in an unconscious patient. A patient cooperation for swallowing what is a relatively unwieldy, thick balloon, not easy to swallow, is required to get it down the esophagus. Once you are in the stomach, you inflate. The rest of the tube is lying in the stomach. This inflated balloon is pulled up till it is anchored at the GE junction. And then for this anchoring, usually clips or pads, etc., with pads with the clips are placed at the nostrils. There are also other ways of anchoring it to the head end of the bed of the patient, but these are not widely used today. In the small minority of patients in whom gastric tamponade inflation alone does not achieve arrest of bleeding, then the esophageal balloon can be inflated up to a pressure of 30 to 40 millimeters to compress the varices directly. And usually with this combination, hemostasis is achieved. And that is usually done using a sphygmomanometer, so that you can, when you're inflating, you connect it after that to the mercury sphygmomanometer and check that the pressure is not too high. If the esophageal balloon is inflated at a very high pressure, 50, 60 millimeters, then significant necrosis, maybe even full thickness necrosis of the esophagus may happen. Now, the Sengstaken Blakemore tube is highly effective when properly placed and properly inflated. Over 90% of the times, massive bleeding can be controlled. It allows time for resuscitation, for transporting the patient from the periphery to a tertiary center where other techniques are like radiologic shunting, etc., may be available. But the problems are that you cannot keep this balloon inflated for more than 24 hours. Even 48 hours is pushing it a lot. Most people would have to, a definitive intervention thereafter may have to be done within 24 hours, and up to half the patients may rebleed when you deflate the balloon. So deflation is usually done in the endoscopy theater with the readiness to do endoscopic interventions when you deflate the balloon. Serious complications like esophageal ulceration, aspiration, pneumonia, and rupture of the esophagus when in inexperienced hands, the balloon is not properly placed and the gastric balloon is inflated in the esophagus. The gastric balloon requires a volume of about 250, 300 ml to inflate. And if this is wrongly done in the esophagus, then you will have a rupture of the esophagus. So esophageal balloons are generally rarely used. You never inflate the esophageal balloon alone. It is done as an adjunct after inflating the gastric balloon, achieving tamponade and still not reaching hemostasis. You have to make sure that A, the balloon is properly positioned by a chest X-ray, the gastric balloon. B, that it is not leaking and has not got deflated. These may be reasons why even after inflating a gastric balloon, apparently inflating and applying tamponade, bleeding does not stop. If these things are checked and not found to be the case, then esophageal balloon inflation and direct tamponade may help in achieving hemostasis. Because of the problems, the complications, and the fact that the esophagus is completely occluded so that even saliva cannot be swallowed and the aspiration risk is significant. Of late, the Danis Ella stent developed in Czechoslovakia has become fairly popular and is now available in our country and in many parts of the world. This is a removable, covered, self-expanding stent, which has basically been used in the lower esophagus. There's no place for gastric variceal bleed. The good thing is that it can be left in place for almost 2 to 3 weeks, and then it can be collapsed and it can be removed. This time allows patients to stabilize. It can also allow time for, say, a tips or some preparations for surgery to be done and to improve the patient's general condition. If there is infection, encephalopathy, all those things can improve. This is what it looks like. There are radio-opaque markers at both tips, both ends. It is about 25 millimeters in diameter and 135 millimeters in length. And these are some of the steps that showed how it is placed. Just like the Sengstaken tube, there is a balloon to guide us, and it is placed, can be placed at the bedside, does not require fluoroscopic placement. It is fairly stiff, and once you cross the pharynx, it is easily introduced into the stomach. There, this balloon is inflated, and you pull back the stent till the balloon is hinging at the GE junction, and thereafter you can then proceed to release. As you can see, this is the sheath is being pulled back and the stent that is constrained at the lower end is being released. And this stent, as it is released, expands to its size of 25 millimeters. It's a covered stent. And this is what it looks like once it is placed in the esophagus. The lumen is wide open, and between the stent and the esophageal wall, all the varices are tamponaded. And when you have to remove, there is a thread at the top end which you catch with a forceps and you tighten. Then, like a concertina, this whole upper end will collapse, and the stent can then be pulled out. So the advantages of the Danicella stent, uh, the only problem is the cost. It's over about 80,000 to a lakh of rupees, and it's not readily available unless it is regularly used in a center. But you can leave it in place for up to 14 days. Oral intake or Riles tube placement is possible. And this in a situation when you have a CTP-C patient with post-EVL ulcers bleeding, very few things work. While the LR stent will work in this situation, and then one can resort to tips and portal pressure decompression. I don't think I'll spend time on tips. We are probably running out of time, so this thing can be covered. So tips can be used as salvage methods, and now there are data on early tips following the first episode of bleeding, if this can be done, and this has been shown to improve survival overall without increasing the risk of HE when you do it early. So, I mean, the tips is a large volume of data available with tips, and I don't think we can do justice to it in 2 or 3 slides, so I'll not dwell into details. Quickly show you something about the hemostatic powders. As a salvage method where nothing else is possible, expertise is not available, but these various patented powders, hemospray, Ankerford, blood stopper, AMP, endoclot, are now available, and which are then directly sprayed on the site of bleeding, generally more effective in diffuse mucosal bleeding like in portal hypertensive gastropathy. When in this, as you can see, the generalized extensive gastropathy is present, and there must have been previous bleeding. So it is simply passing a tube through the biopsy channel and with a air pump attached, and this spray can then be sprayed all over the mucosa. Now, there are good studies and data to show that even in ulcer bleeding, in variceal bleeding, one can achieve good results with the hemostatic powder in massive bleeding. Some of the studies which I don't think I'll be able to go in. The bottom line is that bleeding in esophageal varices in 83%, in gastric varices in 10%, and in spurting bleeding in 43%, while active bleeding in 57%. All of this could be controlled using hemospray. But again, as you can well imagine, this is a short-term measure, buys you time till you are able to stabilize the patient for a more definitive intervention, whichever may be chosen. So last slide is, after in an acute variceal bleeding, you must resuscitate the patient, and these are the various steps of resuscitation which you've spoken about. As soon as the patient is stable, but generally within 24 hours, gastroscopy should be done. And band ligation for control of bleeding is the standard of care, along with antibiotics. And once bleeding is achieved, then the patient moves on to a schedule of secondary prophylaxis with band ligation to be done at 3 or 4 weekly intervals till eradication. And in case of failure to control bleeding, balloon tamponade may be required in an unstable patient, or a Danicella stent. And thereafter, once assessment has been completed and it has been, the assumption is high portal pressure, often readiness for band ligation or tips should be available. In case after secondary prophylaxis there is rebleeding, again one resorts to tips. While for gastric variceal bleeding, cyanoacrylate glue injection, which is probably in a large area in itself, gastric variceal hemorrhage, may have to be taken up in a subsequent session. In rebleeding, again, one resorts to tips. So sclerotherapy and ligation have revolutionized the management of variceal bleeding. These are basic techniques that must be mastered by every gastroenterologist. And there are vast troves of information, data, meta-analysis, guidelines about how to use these tools and what to expect from these tools. Newer techniques are continuously evolving, including various intervention radiologic techniques and surgery. And now a proper choice needs to be made by the well-informed gastroenterologist handling patients with acute variceal bleeding. Thank you very much for your attention.
Thank you. Thank you, Dr. Saraswat, for giving a very good overview of endoscopic management of acute variceal bleeding, especially from surgeon's point of view. I think every surgical student and surgeon should know the basic principles of what our colleagues do. And I think some of our surgical colleagues, either by choice or per force, do these procedures themselves. So it is good for them to know the basic principles. Krishna, anything you want to ask?
Sir, so basically in places where endoscopy is not available, science tech and black tube is placed and the patient will be shifted.
Stabilize, start vasoconstrictors. Vasoconstrictors should be available everywhere. So terlipressin or octreotide or somatostatin should be started. And while you are transporting him to a place where definitive treatment can be provided, if the patient has profuse active bleeding, is unstable, then balloon, sense-taken balloon would have a place. But overall, the use of balloons has gone down because the experience with the use of balloons is now very restricted and people are not experienced and not confident of placing the balloons. So they get underused. The Ella stent, they comes with an instruction manual and all that. And if it is available there, it is highly effective and can be used. But again, the cost is a concern. For the cost of an Ella stent in many academic centers, you might actually get a TIPS placed. So all these things have to be borne in mind, and depending on the situation and the availability of these tools, they should be used.
Any instructions is we have to keep when we have to transfer the patient. If we have to transfer the patient to a higher center, any instructions for transporting and during the transport with this?
Well, the standard thing that you would do for making sure that if a Ryle's tube is placed, no tamponade has been done, then they one will have to keep doing aspiration and lavage and keep the patient in a lateral position. Check the hemodynamics, have the infusion going smoothly. Depending on the distance to be transported, if blood has been arranged, blood can be transfused. So these are the usual standard common sense precautions, and usually obviously ambulance with a trained nurse or with monitoring equipment would be required to transport these patients.
But again, as you said, that if the Sengstaken Blackmer tube is available and if it can be placed in an appropriate way, it is a definite control of bleeding at least for 24 hours while the patient receives proper treatment.
See, unfortunately, what has happened is because of the lack of availability and lack of popularity of this, the imported Rouge brands are just not available. They were quite stiff and easily passed and very durable. The Maquet is a French company that is making it, and there are some local companies in India manufacturing it. We have tried these balloons on several occasions. They are quite soft, not easy to place, and problems with leaking and so on. So A, the quality, availability, B, the quality of balloons, and C, the expertise in placing the balloons has been diminishing. So while this is an excellent tool and everybody should, I would say, I think that in simulator models using dummies, people should get practiced and be expert at placing it, because in a life-saving technique, you don't do a CPR every day. But if you don't know how to do a CPR, you will never save lives.
Yeah, that is a very important point, that it should be a part of the training. And what is happening today, that since I have not learned, so my tendency, whenever I am asked to use it, I don't want to use it, so I don't get it in my thing, armamentarium. So it's not available. It's a vicious cycle. But this is a very important part to overcome. It's a fantastic tool for that particular situation, because endoscopy is not available. You are stuck into a situation.
Chaubey and I, we are roughly of the same generation. We are talking from the same center and the same place.
I have only used once. I was in a very VIP place, gone on, or had this campaign thing. I went to Wellington. And that Wellington hospital is not highly equipped, but it's very VIP place, because the one fellow came like this, and they had a Sengstaken tube, and I had never seen this thing. But what they had that instruction, nicely written instruction. So I read the instruction, I passed it.
And exactly, that is there, and I think at the All India Institute, where both of us train, and at SGPGI we have used it regularly, and we have saved patients. You buy time. See, I mean, you are in a tertiary center, but the patient doesn't have the funds for a TIPS tomorrow. So you have to get time, give them ready to generate, resources, and even if you have to resort to things like emergency surgery, at least achieve a level of stability so that the chances of success of whatever intervention is done are better.
In today's curriculum for NCH and DM, it should be a simulator based training.
Yes. Ajay.
Sir, I think I'll just put on a few points which may look absurd to your specialization, but from a surgeon's perspective. So, first of all, I'll just start this with the sensitive blackmore tuber. I feel that sensitive blackmore tuber is most common problem is non-availability. Most of the patients bleed in periphery, and the peripheral centers don't have, even in Jaipur, there will be only few centers who will have sensitive blackmore tuber. Second thing, comparing from a stent from a tube, I think sensitive blackmore tuber has the biggest advantage of controlling the gastric varices, and which is not available with any other method to salvage the patient. Now, my question is, other than this is, you said early pressing and or octreotide. So, can they both be used simultaneously, or they have to be used one? And second thing is an octreotide replacement of terlipressin? Because octreotide is available at every place, terlipressin is not. So, for the people who are doing it at any other center, is it a replacement?
Yes, by and large, most of the data are available with terlipressin, and it has shown to be very effective. Large randomized controlled trials are there. Now, octreotide and or somatostatin, but mostly octreotide is readily available. It has been found to be equally effective. So there is non-inferiority to terlipressin. If terlipressin is not available, then one would use octreotide. But in the odd patient, while the trial and data don't talk about it, but it's not, we have had the experience that after using octreotide also, bleeding is not appearing to be settling, then one may be tempted to shift to terlipressin. But for the first effort, if nothing is, if tele is not available, octreotide is available, then I would not hesitate in using octreotide. Octreotide is different, 250 microgram, 500 microgram loading, and then 250 microgram boluses have to be given every 2 to 4 hourly.
Normally, as a surgeon, we give 100 microgram TDS subcutaneously. From your perspective, the first dose is 500 microgram, and then
followed by 250 microgram boluses that can be given about 8 to 12 hours. Yeah. So that will give us results which will achieve hemostasis comparable to what we get with
match the
So next question is told that the mean blood pressure for a patient with a variceal bleeding has to be kept around systolic 100. What our impression was that they have to maintain a mean pressure of normally we try to achieve 70, but in this group of patients it's slightly lower. It is better because it is the risk of blood. Maybe I'm wrong, but maybe I'll have to.
Sorry, I mean what I meant was that the mean systolic pressure, not the mean arterial pressure. Mean arterial pressure would be what you were saying, around say 70. Mean arterial pressure, but mean systolic pressure should not drop below 100. So there, if you can control that, I think what you're saying also, that it will also decrease the risk of ongoing bleeding. That part also will be applicable.
The sensitive blackmore tube, you told that you have to fix it to the nasal.
It has to be passed nasally,
and then you have to pull it and fix it. I remember Dr. from Mumbai. He had a very beautiful trick that was the helmet. Use a helmet. I used to fix it to the helmet. I think that is a.
I got this helmet. It was a tripod mask with 2 legs, 2 placed over the malar eminences, which you can place, and thick plates of plastic. I got it done in made at Ames. They had a workshop there, which has that allows the tube to traction to be done through the nostril and anchor it like a baseball player's mask. So you are placed it to the mask, and then that way there is no pressure applied on the nares. Now, in most places, these is not available. These masks, they have not been made. So what people tend to do is to apply traction, get the firm traction, and use an ID set जो cover होता है, the stiff plastic. Wrap it with tape and fix with the tape. Fix it there with a mark on the nostril.
Yeah, that's a very good. Forward to that question. Forwarding to that question, Ajay's question. Now, my this thing is that that pressure. 40 millimeter you have to maintain in that esophagus. So, so how do we now, earlier we to attach it to that sphygmomanometer,
Now mercury is outlawed.
And so now that spirometer is not available. How? Because I have never used it, but now this question has arisen: how do we maintain that 40? Because that's very important. How do we do that?
Mercury is not the only way. You can probably do it with a regular manometer also with a connection using the.
अच्छा वो manometer में connect कर दो हाँ ठीक है उसमें भी कर सकते हैं yeah. That, we can connect into that. There should be normal.
But the last slides you have shown that you use hemostatic agents for the
powders, hemostatic spray.
So for a surgeon or a peripheral person practicing who is not doing endoscopy, can he pass the rice tube, and from that rice tube can he inject some hemostatic agent which will control? Is it
not been described? Nobody has used it. The problem with these powders is that whatever is the catheter delivering it, and the powder has to be completely dry when it gets delivered onto the surface. Now, when you pass a rice tube, it's very difficult to keep it dry. Some fluid, some blood secretions will go in, and the powder will congeal within the tube. So what you do is through the endoscope, you keep the thing completely inside the channel, and once you're nicely in the scope, got a good view as you saw in the video, then push out the tube, and then that powder can be sprayed. It will remain a powder.
They are the same powders which we use for surgical practice, that we use this thing, Surgicel and surgical powders, or something.
This is an offshoot of war surgery.
Yes.
In a war surgery, if the people who go into a frontline war, is something called personal kit, and it's a part of there's a dressing. So if there's a bullet injury to you, you have a thing. So that dressing is like that. It's a big one. And that's impregnated with this type of agents, and you apply. So it applies the pressure as well as
all the glue you talk about. Glues came from the Second World War. Battlefield injuries, to stop bleeding, you would cover it with cyanoacrylate glue or octyl cyanoacrylate to achieve hemostasis.
The dressing is impregnated with the powder. So you apply that.
Many of them are actually patented molecules, so they never tell you exactly what it contains.
Yeah.
I'm not sure whether you can compare it with the surgical powders.
Because last time I saw somewhere in this Indian DRDO, they developed this thing, and those dressings.
There are two practical points. One is that if at all you use Sengstack and Blackmore tube, don't take it up and fix on the forehead, because that curve will cause the necrosis of the ala nasi. Second, what Dr. Ajay asked and Dr. Saraswat replied, that the dose of octreotide for bleeding control is not the same as we use in pancreatic surgery. There we use 100 micrograms subcutaneous 3 times a day. Here it is 250 microgram bolus every 6 to 8 hours, isn't it? Yeah. So please remember that.
One question, आपने बोला कि during the acute variceal bleed, that pressure, that portal venous pressure, how do we measure that during the control of bleeding? 20 meters, you said.
That is HVPG, hepatic venous pressure gradient, through the internal jugular vein, that we measure the hepatic pressure.
Okay. Yeah.
So many centers have the practice that as soon as a bleeder comes in, they are taken to the HVPG lab, and that can be done, or once you've stabilized them.
Okay.
So that number of more than 20 millimeters is within the first 24 hours after the bleed, which means you have used pressure lowering agents, you have done, you have given terlipressin, yet it is about 20. So actually, when the bleeding is happening, it's probably going to be higher.
So they do it regularly.
I think we will close the session. Thank you very much, Dr. Saraswat. Thanks.